Okay, so before we begin, I just wanted to once again thank all the stakeholders for coming to learn about a behavioral health topic of interest. This month, we're going to have Dr. Mike Franczak, who currently serves as a Director of Population Health Services for COPA Health. And Dr. Mike has been involved in mental health, substance abuse, intellectual disabilities in not only Arizona, but Pennsylvania, North Carolina for the past 40 years, as well as Arizona. He served as an expert witness in many landmark cases concerning mental health, intellectual disabilities, and is currently expert to the U.S. Department of Justice and Civil Rights Division. Dr. Franczak has been a primary investigator on numerous grants for the SAMHSA, including housing approaches for persons with serious mental illness, jail diversions for persons with serious mental illness, integrated substance abuse, mental health treatment programs, and model systems of care practice for children, adolescents, and substance use services for adolescents. His current work it focuses on analytics to create actual information to improve individual outcomes. And Dr. Franczak was also awarded the Mental Health America Hall of Fame Award in 2018 here in Arizona. What you're going to see is a lot of information on the screen of what Dr. Mike uses as they follow people. He'll also talk to us about what's really worked for those numbers of friendly faces, high utilizers, whatever we want to call it, and what have they found that works. So you're going to see kind of the mechanisms, and then he'll talk about what they have found through use of this data. So let me go ahead and share the screen.
Yeah, before I talk about artificial intelligence, good afternoon, everyone. Thanks for attending. Before I talk about that, I want to talk to you about what population health is about. It's a term that's started maybe about 10 or 15 years ago. And population health has several functions. The first function is that we look at the entire group of people that we are serving and try to identify what services we need to provide. So, for example, COPA Health serves approximately 10,000 individuals with a serious mental illness. And we look at, okay, what are the behavioral health disorders that the individuals have? But we also look at physical health disorders. We're integrated, meaning we have our PCP and our behavioral health working together in the same clinic. So many of the individuals with a serious mental illness have co-occurring medical conditions, diabetes, hypertension, obesity, and other conditions that we need to be prepared to treat or need to be able to connect with people or agencies that can treat those conditions. So the first role of population health is know who we're going to serve and make sure we have the services that they're going to need. The second aspect of population health is to look in greater detail, take a deeper dive into what's going on with people who don't seem to be doing very well. And that's usually manifested by frequent emergency room uses, frequent hospitalizations, lots of readmissions, people who are picked up by police, people who are homeless, people going to urgent care centers. And in the population of 10,000 people we serve, we usually find about 500 people in that category. So many people are doing okay. That is not to say that we can just assume because you're not going to the hospital or emergency rooms, you're doing okay. We are also have a check to see that that's continuing. So people can and do recover. So when I talk about artificial intelligence, it's become very, very popular word that has come up, AI. And AI frightens some individuals that it's going to take over jobs, it's going to take over professional decision-making. And people are just nervous that AI has the potential to change the way we live entirely. Now, AI has been around for a long time, and AI in mental health care or healthcare in general, and I'm going to ask our physicians on the call, Dr. Goldstein and Dr. Honsberg, whether in their careers they encountered HI and whether they felt HI or AI was taking over their ability to practice medicine. But in fact, we are all subject to AI on a daily basis. If you bought anything from Amazon, if you ordered anything online, suddenly you're getting all kinds of advertisements in your email or on your text about similar kinds of articles because they know your choice-making process. So they know you like to read James Patterson detective novels. So suddenly you're going to be confronted with that all the time. Now, moving to the first slide after the intro, Lori. Now, we've gone through massive technology changes over my career, and the changes have brought what are electronic medical records and all kinds of diversified data. In matter of fact, when I look at all the data we have coming in from various sources, which I'll show you a little bit later, it goes into a data lake, and then it goes into a data warehouse. And in my experience, much of that data goes into what I call a data graveyard because it's never used for any purpose other than to collect it. So it brings great value to healthcare. It's a great tool, but it's not perfect. And in fact, AI has been very effective in other kinds of industries. I'm going to call on Lori, who worked in a industry where AI was probably a crucial part of their production. Right, Lori?
Absolutely. Remember search engines?
Yeah.
Those are all algorithms, and then it gets to the point where humans that help program it can no longer say why it's selecting a particular asset when it's organic and it's not forced.
Well, in a lot of ways, the AI has different levels. And in your industry, I think you're working on a machine learning level, where the machine has more abilities to identify anomalies or bring in additional data, and it does take off. But data is essentially essential to programming, it's essential to care and quality improvement. And one development in it is their analytic techniques that can be used to help a practitioner identify things. Now, some of us still kind of like paper medical records. They seem to be easier to use sometimes than electronic records, which have a lot of redundancy built in. But in fact, when you're seeing a person for care, AI can bring all the information you need about that care right to you immediately. So it saves a lot of shuffling and trying to find pieces of information. But AI is no different than the human learning process or decision-making process. Every day we make 50,000 decisions about things, little things. Whether we're going to have a cup of coffee or a cup of tea, or when are we going to brush our teeth or put on our socks, or whether we're going to do this. Those are all little decisions we make. Well, AI has a way of studying the decision-making process, but AI is created by a human being who's putting in formulas and instructions to a machine that tells it how to sort and collate and separate information and bring it to the front. So moving to the next slide, and I don't like to do slideshows. There was a great comic, there was a great cartoon in the New Yorker many years ago, which said the devil was interviewing this guy for a job. And he said, I'm looking for someone experienced in torture. And the guy says, well, I know PowerPoint. And he said, you're perfect. So I don't want to do too much PowerPoint. But anyway, we have artificial intelligence. What we do is take it and turn it into assisted intelligence, which helps the clinical teams or the clinician to use the information that has been abstracted to do better care. So we then take that information and turn it into actionable intelligence, meaning, okay, now that I know all the information I need, and it's given me these facts, I need to turn it into something. So that's what we're going to talk through. So let's go to the next slide, Lori. So let's start out with AI. It's where multiple data sources are centralized. We now have a health information exchange that gives us what's known as an ADT portal. And ADT stands for admission, discharge, or transfer. So providers feed into the HIE information on who's in the hospital, when are they discharged or transferred. And we get that information in a batch report every day. We also have value-based contracts where our payer sends us information based on their utilization and authorization about who's going where. We have data coming in on other programs, TIP programs, EMR, and we apply algorithms and statistical analysis and simulations with that data. But AI is limited, just like a human being, to what it can ingest. And like I said, in healthcare, many pieces of information are not digestible by a computer. I'll give you an example. We send people out to get labs, okay? Labs are important to know how people are progressing. Labs come in on faxes to our record room. There is no way for our EMR to digest that data and to put it into our artificial intelligence engine. So many things are happening in progress notes that cannot be ingested. So artificial intelligence, by its very nature, is giving us limited information. So the next step, moving to the next slide, this is just an example of how we feed this data lake, which we get information from Contexture, which is our HIE. We get information out of our EMR, which is NextGen. We get information from Kronos, direct from Mercy Care, Relation, Psych Surveys, and other. All of this data goes into the lake, and in the lake, and just like any lake, it isn't that pure. So some of the data is kind of less than useful. We then bring that data together for a particular person. When was Mike last in the hospital? What was the diagnosis? What were the medications? We put it all together, and then we bring that data out into what we call Nexus, which is where all this data comes together about individuals. And then the clinician gets alerts when they open it to say, okay, here's the information I have on Mike. But that's just the start. Moving to the next slide. One thing I can show you, one thing we did was with A1Cs. And A1Cs are important as diabetes, showing a person, getting closer to having diabetes. So we get the lab orders, the COPA orders. We get third-party lab results coming through the HIE. When we get lab, we do it ourselves. We get information that goes into NextGen that's digestible. Third-party results from the HIE are not. And then we export that daily into our analytics app. So in our analytics app, we're able to go and see cohorts, people who have A1Cs above a certain level. I think we picked 6, but indicating that their A1Cs are a problem. We then bring, bring them in for appointments if we can. And then we look at and track our A1Cs based on the treatment we're providing. And those reports are sent out to the providers on a weekly basis. So they know that Mike's coming in this week, his A1C is a little high. When he comes in, you got to look into it and see if we are doing the right thing. So moving to the next slide. This was on no-shows. And, no-shows are a problem across healthcare. And they're particularly a problem in Medicaid. And I think in Medicare. So what we started seeing is that while we schedule appointments for individuals to come in, a certain percentage are not showing up for appointments, in spite of the fact that we give them, the standard calls, you're having an appointment tomorrow or the next day. And so we look at our scheduling and we look at who showed for appointments. Now, appointments that don't happen, no shows, create a problem because it's dead time for the provider. It's non-billable time economically. It's also a problem that the individual isn't getting care. And if they're on prescription medications, they're not getting prescriptions filled. So it's a cascading set of problems that are created by this. Now, so anyway, we study very closely the show rate on appointments, and we export it into our analytics tool. And we're able to pin down, okay, who isn't showing to a particular service or to a particular provider or a particular location. So that gives us information that something isn't working. We can also use it to predict who's going to show and not going to show. And then we can actually intervene with the individual and say, what's up? Why aren't you coming in? What do we need to do? Is it a transportation problem? Are we not doing something you need? Particularly with the homeless population, no-shows are rampant because we can't find them. So, but what we've been able to do is cut our no-show rate in half, and it's still going down as we implement different ways to engage people in care. So, Lori, if you want to go to the next slide. The next slide is, okay, we got all this great information. What are we going to do with it? Well, we know the people, the places, the patterns. We use the Toyota model of 5 whys. Why aren't they showing? Is the first question. And we keep asking why, until we actually come down to a hypothesis. There's also the field of behavioral economics, which has started in the last 15 years. And the folks who are doing behavioral economics have won a Nobel Prize for it. And it's studying how people make choices and decisions. And it's very interesting. And we're going to get to that a little bit later. We look at our value-based care measures and how that's fitting up, how we're doing with those. We look at appointments, no-show rates, readmissions, engagements, and the performance of each clinic and providers. At one point in time, we're able to identify this provider has an 85% show rate. This provider has a 50% show rate. What's different? And then we try to study and work with the provider to improve their performance. So next slide, please. And then we try to identify the specific problems. Why aren't they showing? And usually, and we do this in a team fashion in what's called an integrated care meeting, where we bring the folks together who know the person. And then we talk, okay, who has an idea of what's going on here? And we try to develop hypotheses. We do simple science. We say, okay, they're not showing because their transportation provider has been inconsistent. They're not showing because they don't like the service person, that we need to consider something else. Or they're not showing because they don't like the service, they don't like groups, they prefer individual. And we test the hypothesis over time in our action to see if we can make a difference. So the next slide.
So Mike, a question.
Yeah.
So say you have an example and you used Mike, just an anonymous Mike, and he's a no-show and he's not taking meds or whatever. If you send transportation and he still doesn't go into the clinic, he just bolts from the taxi or whatever, then where do you collect all of the various interventions that you've tried on each individual to see which worked and which didn't? How do you capture that in the system?
Well, we capture it by, in the integrated care meetings, we do what's known as a functional analysis, where we identify all of the previous interventions and which ones worked and didn't. You know, sometimes we see individuals in supported housing, supposed supported housing. And when we look at why they keep failing, we see that no supports were provided to make the person successful, or they're going to a substance abuse treatment program that is abstinence only, and they're not going to stay very long. Or they go to a group home, and the group home has rigid rules about you can't leave without us walking with you, you can't go to the store, you can't see your parents, you can't talk on the phone. And we identify interventions that have been successful and interventions that have failed. And we try to get them back to an intervention that showed success over time. And we track the data on their frequency of usage. If they're not showing, what are they doing that we can capture through utilization? So, for example, we had a person that was not showing probably about 75% of the time when we had an appointment. He also showed that he went to an emergency room 95 times in that interval. And we're trying to figure out what's going on here, right? And the simplest thing is this guy lives a very isolated life. And we placed him in a residential program that was next door to an emergency room. So the emergency room people, who were very kind and got to know him very well, it was like their neighbor. And while he'd go in there, they'd have to do something medical, but he was doing it because it was isolated. We got him involved in groups and also more involved in clinic activities. And it went down to about a third. He still goes to emergency rooms. He likes those folks, but it's, there's a lot of reasons people use emergency rooms. But anyway, so we try to do an analysis of where's the problem occurring? Where is it not occurring? Where didn't it occur? You were in a substance abuse program that was harm reduction. You stayed there for 6 months. You were doing well. When you left that program, you fell apart, and people kept placing you back into a, abstinence only program where you're probably going to fail. So we look at what, where, when, and to what extent. So moving to the next slide. So like I said, we try to use a kind of logical approach. We name the hypothesis and what's the true cause and where it's happening and where it's not. And what I found in these meetings, and I go to them every month, we have a meeting on each campus on a number of individuals who are showing issues, that it's great teamwork. We hear from some of the staff who are the case managers or the peer support, who have the most close relationship with someone. We hear some of the most interesting facts about what's going on from those folks. So credentials are less important than whether they're engaged. And of course, some of our counselors and physicians and others who know the person very well can tell you right away what's going on. So we select the most probable cause, and then moving to the next slide, we implement the cause. This is where data becomes actionable. And actionable data is we identify it, we believe we found the root cause. Like I said, we do the problem, develop the hypothesis. And then instead of having 20 treatment goals for that individual, which we do when we do a comprehensive assessment, we begin to focus intently on the issue that's driving the particular problem, no-shows, emergency rooms, and or hospitalization. And by focusing the team efforts on one goal versus 10 of them, we're usually able to get results. Not always, but usually we get results. So at the current time, we have about 35 people at each clinic that are high utilizers, high need, high cost individuals, where we review the progress on this monthly basis. Moving to the next slide, we're looking at the whys. You know, AI can give us the what, the who, the when, and the where. But AI that we have cannot give us the why. So the why are, we think, you know, people make choices. Choices show us patterns. I call them digital crumbs. Patterns reveal the preferences and the motivation of the person, the why. Knowing the person's preferences and motivation allow us to target our interventions. And we implement and monitor that we hit the right target. So, quoting Shakespeare, and I'm going to get into this in the next slide, Hamlet, there is no good or, and this is paraphrasing Shakespeare, sorry. There is no good or bad decision, but thinking makes it so. So I've gotten to the point where some of us would sit there and say, that's totally irrational that you would go to an emergency room 95 times a year. That's ridiculous. I don't want to sit in an emergency room. And if we consider that irrational, then we're just saying, well, that's evidence of psychosis and bad decision-making and cognitive processing. But when we dig deeper into the why and the reasons for the choices, we come up with some things that are more practical. So moving to the next slide, you know, we implement our, did you skip one? I think you skipped one.
Oh, sorry.
Yeah. Well, you all know Maslow's hierarchy. You couldn't have lived life this long without running into it 100 times. And Maslow did a hierarchy talking about, you know, meeting basic needs all the way up to self-actualization, right? Well, if you flip Maslow's hierarchy and you talk about the people we're serving, who are primarily very poor, and you look at the decisions that they make, and you look at the options they have for decisions, you find that the people we're serving have extremely limited, if any, options. you see the people at top have multiple options. Okay, so if I have a headache, or let's say I ate something and it gave me some, an acid stomach. What I would do is the first thing I do is go to my medicine cabinet. And in the medicine cabinet, I would probably have aspirin or Tylenol, ibuprofen. Might have Pepsid, or, I'd have a remedy. I take care of my issues. Many of our individuals, particularly homeless individuals, don't walk around with a medicine cabinet. Many of our individuals can't afford some of these medications. We prescribe medications, but we don't give them the basic self-care medications. So why a person goes to an emergency room, and I'm not going to talk about the 95 dime guy, but 2 or 3 times a month for a headache, is they don't have any ability to take care of it themselves with over-the-counter medications. Now, and we found that to be the case in with many people. Now, it turns out that prescribers can prescribe over-the-counter medications, but some are reluctant to do that because they don't think they can. But what we try to identify is, okay, why did you make a decision that you're going to go back into the hospital? And we have a lot of people that go in and out of the hospital, and they go from one hospital to the other. And hospitals are definitely appropriate for people who are unstable and need to be in a structured setting for a significant period of time, so that medications can be adjusted so that we have the person stable. However, there's a group of individuals that we've identified in our high need, high cost, high frequency or high utilization group that are going into the hospital because they're either homeless or housing unstable. And they're going to the hospital because the hospital provides, a good temperature in the heat, or a good temperature in the cold, clean clothing, food, a bed. And they're going there for reasons that are social determinants of health, not for the hospital services that are typically required. Now, so why are they doing that? Well, they're doing that because they have so limited options about what they can do. They don't want to go to a shelter. Some folks feel shelters aren't safe. But hospitals provide what I think is great hospitality. They're not the one flew over the cuckoo's nest place anymore. They are inviting, engaging. Meals are good. I sat with a group of folks that were frequent hospital utilizers, and they were talking about the different hospitals. They said, well, Banner has the best food. I like St. Luke's because it has a pool. I was thinking, is this like Trivago for psychiatric hospitalizations? And the other thing is, given that many hospitals are IMDs, and Chuck is the expert on IMDs, that means you can't stay there more than 15 days. We have people that are being released in the same condition that they came in because their time ran out. But some people have got it really down. They're discharged from an IMD, they take a cab to another IMD, and they just continue that kind of, part of that is due to the lack of housing options we have. I heard the other day that there was a 5,600 person waiting list for housing, and that's not supported housing, that's just a roof over your head, right? So should we be surprised about the growth of IMDs in Maricopa County? There isn't a month that goes by that someone else isn't building them. And they're not building them because they're going to lose money. They're building them because we have a deficit in our supported housing. So, Anyway, moving to, which I believe is the last slide. We implement the plan, trying to find alternatives. And it's really tough to find a housing alternative because a lot of people, we can today get residential faster than we can get flex care or any other type of housing. Plus, many individuals, because they didn't have the right supports in the first place, were evicted. So they have an eviction history. So many landlords don't want to even touch them because they know their history. So we try to teach positive, modify circumstances, and then we continue to modify the process until we get a good outcome. So Lori wanted me to talk about a few success stories. We have, and I'm just going to give a quick initial. This is a person named M. And he was in and out of hospitals very frequently. He would do well upon initially discharging, but he would start to decompensate pretty soon thereafter. When we sent him to a behavioral health residential, he wouldn't engage in the groups and eventually end up in the hospitals and amendments. By the way, at any point in time, Partners in Recovery has about 600 people who are on COT commitments, meaning they need to come in to get their medications. And we have a number of people who've had to be amended 5 or 6 times because they wouldn't follow. So one of the team members eventually was able to build a rapport and find out what are the triggers for him that were causing this kind of readmission and address these concerns. We eventually found a group home where he wasn't required to go to any kind of groups, and he was allowed a bit of freedom. After that, he was able to leave that group home and move up to a flex care program, and the hospitalizations dropped out quickly. We've had other individuals we were able to get them in the right substance abuse program, and there's a shortage of those as well. But the key to him was he didn't have any supports whatsoever in the community, and his brother was living up in Flagstaff, but he was disconnected. When he was doing well and the brother didn't want to deal with him while he was using substances, the brother started participating in his treatment, and eventually he moved in with his brother up in Flagstaff, and everything's been going fine for him. We had another individual who was high profile because he was involved in a shootout with police. And he was on the list for about a year. And until we got him coming in and taking his medications, by the way, a big breakthrough was the development of long-acting injectables. Some people do not like injections, shots, but we found tremendous results with people taking injectables, because we can go to 6 months now on an injectable, and the person doesn't have to get shots every month. They have to start out in that way. But with taking injectables, his cognitive processes cleared very quickly, and he was able to complete his court-ordered treatment and continues to engage with his team. And the real key is, we do things like we do these comprehensive assessments and look at it, and then we tell the person, hey, based on this assessment, here's what you need. And what we really need to do is take a step back and start with, what do you think you need? Because telling a person everything they need often gets us nowhere. But asking them, how can we help you? And what do you need? Gets a foot in the door. Because usually they're able to quickly identify, I need a place to live. I need, something to do during the day. I need, all kinds of things. I need some food boxes. I need somebody to take me down to Social Security. I need somebody to help me renew my access. Doing something for a person builds the first piece of engagement. So I hope I wasn't too boring on what AI is about. It's, by the way, AI is interesting because AI, like I said, uses algorithms. And algorithms were developed by Muhammad al-Khwarizmi, who apparently was a mathematician who developed algebra. So they kept the name with algorithms as well. And it was done in 800 AD. So we're just beginning to recognize the brilliance of that. And I don't think we should fear it. I think we have to make sure that it doesn't take away decision-making from the clinicians.
Yeah. But you know what, Mike? I mean, even with advances in medicine that I'm sure you're aware of, but they're just feeding information of tumors like pancreatic cancer or various cancers. And what it's doing nowadays is it can just, like you were saying, it alerts the clinician, like, this looks abnormal. They're not telling them exact, but they're saying, pay attention here. And they're getting really good success in early detection before it becomes, at a further stage.
Yeah, well, there was an article in the Wall Street Journal a week or two ago that talked about how this one clinician was saying Kaiser Permanente was going to discipline her for not following the algorithm. I don't know, Chuck, did you see that article? No. The algorithm said this person has sepsis. And she was saying, no, they don't have sepsis. They have leukemia. And there's, the lab test is going to get confusing. And she was right. And Kaiser Permanente denied that they were punishing people for not following an algorithm. But any other questions? I know you have other business.
I think, so it's interesting that you found certain things. I know in the past you've talked about with changes in data streams and data feeds, often clinicians and providers were not able to see who's picked up their medicine and who hasn't. Has the HIE or any of your data sources now gotten that closer to where you can tell who's picking their meds up and who isn't?
Yes, we can. But Copa Health has 2 in-house pharmacies. We have Genoa and Community Pharmacy, and every one of our clinics have an in-house pharmacy. In their cases, and as a matter of fact, I'm working on an algorithm to identify this, that they're able to say, that, and there's a HEDIS measure. We're being measured on adherence to medication for antidepressants and antipsychotics. And the pharmacy notifies the clinical team 7 days the person hasn't picked it up and they've tried everything they can, so that the team can call the person and say, what's up? You don't have transportation. The medication isn't, you don't feel it's working. This medication is causing side effects. We problem solve with the individual about why aren't you coming to get your meds? And then we deliver it. We set up transportation. We do everything we can, because in many cases of serious mental illness, the chemistry is extremely important in making sure the person is clear. And so we've set up algorithms, and we know who isn't, and we know who is. And we're trying to get a handle on that. There is some research that 80% of well, this is true of most medications, particularly antibiotics. People stop taking them when they feel better. Well,
Mhm.
that's not a good idea, particularly with antipsychotic medication. And so we have to be, closely be sure. Now, we don't know that they actually took it. We know that they picked it up from the pharmacy, though. So,
Yeah. So Rachel has her hand up.
Hey there.
hi.
Hey, great presentation. I also did process engineering at Motorola with Lori, different departments, and Six Sigma black belt. So I was really geeking out on your whole presentation. I love it. My one challenge I think is that all the data being collected, it's kind of only looking at the people being treated that we're actually touching. Is anyone looking at the greater community stats? Like what percent of our SMI population is in jail? What percent of our total, for all of Arizona, for all of Maricopa County, what percent are actually getting treated? What percent of psychosis disorders are getting long-acting injectables or getting the clozapine and things like that. A lot of the metrics I've seen where, hey, we've got great people finishing a program, but it was a voluntary program. We didn't look at how many people in the whole program elected to have that voluntary service. So are we looking at the greater community metrics with all of this? At least looking at comparing it to the incident rates of mental illness and SMI and psychosis disorders?
I would say in general, no, but some of the questions that you asked, I can tell you how many people are getting Clozaril. I can tell you how many people,
Right.
There's a group of people within our population that don't want service. And they're on what's called the navigator level. So we routinely look at the navigator level to see what's going on with that population. Access does have a database. And again, it's still people enrolled with Access. It's not the whole population. I don't know. Chuck has always looked at those kinds of things in his, he likes to have a bigger picture. There are a lot of folks with a serious mental illness that are not being treated, for sure. And whether they're getting it from their private psychiatrist or not, Access wouldn't know. I'm not sure who would know, who should know. Chuck, do you have an answer to that? Who you think is, if they're doing that?
I'm not sure.
Yeah. Yeah, it doesn't seem like anyone's looking at that at this point in time. Although the Treatment Advocacy Center does do some things in that area.
Do you get, I know you said in the old days, you, as the teams, the clinics would get a voicemail or a message that one of their people, one of their patients or one of their team is in jail. Do you still, if they're enrolled in Mercy Care or enrolled, do you guys get notified when they hit the jails, and what do you do when that happens?
Well, we have, and this was a long time ago when I was involved in the jail diversion study. We set up something called the Jail Link. And yes, if someone goes to jail, we are notified that they go to jail. After that, we communicate with them, provide them with, medical records regarding the treatment they're receiving, particularly medications. And we have routine, supposedly routine. It's sometimes hard with jails and COVID threw another layer of problems in there. But we connect with the jail to see that they're getting the medications. And we also prepare for their release. Now, sometimes the jails are releasing people at odd hours and odd times, and that's a problem. But most of our folks, one of the assets we have if someone's on probation or parole is we involve the parole or probation officer in our clinical teams to make sure we're all on the same page.
Do you also in your information, if you have a patient and they're in the hospital and the hospital docs, the inpatient docs decide to change all their meds, all of a sudden, you know, this happens, you see them, they go to CBI or wherever, and all of a sudden they're on different meds when they come out after they're in hospital stage. Do you see those disruptions in medication?
All the time.
Huh.
All the time. We have a requirement that we're supposed to see the individual back at our clinic within 7 days of their discharge. And we have been picking up people at their discharge and bring them in to make sure that the meds are back on track. You can't just like flip meds. So sometimes you have to let the other medication, you know, expire or the half-life so that you could restart your medications. Hospitals have a different, you know, when someone comes into a hospital really agitated, they're using medications to calm the person down as much as possible, right? We don't, that's not the way you live in the community, as being very calm. So sometimes we, you know, have to get back to a community regime that a person can live their life in and take medications that are more appropriate.
What do you have it listed if the person has guardianship, has guardians, so they're involved in some of the decision making process?
Yeah, we are. We have, you know, the guardian's involved in all treatment planning and should be involved in the assessment. You know, the importance of family and the supports they provide the individual are immeasurable. And by having families involved, we had great success with some of the really high utilizing folks who the family knew what's going on and was able to participate and tell us what we really needed to do. So we do have guardians. We have pub fids who sometimes are great and sometimes they can be obstacles, or their decision making that we don't feel is in the best interest of the person, but we work it out.
Other questions for Dr. Mike?
Well, I hope I dispelled your fear of artificial intelligence.
It's a tool.
It's here to stay.
Mhm. Well, you're welcome to stay. I will, if everyone is done, I will stop the recording. And if people want to share what's going on with their families or people in the system, we'll go ahead. So let me stop the recording.